Good morning. We're going to go and get started. I'm just going to put my readers on so I look seasoned. So my name is Brian Coleman. We're a pediatric emergency medicine doctors here at Memorial. Tim Galey, one of my partners here. We're going to go through some kind of a literature review of some recent studies looking at some of the daily problems you probably face and over any given shift. Our goal was really to try to kind of use these studies as a backdrop to bring home some points, some practical points. So we're really not going to kind of get into the nitty-gritty in terms of study details and kind of dissecting the studies, but hopefully we'd like to make some practical points. So please stop us if you have any questions. We're going to try to do it kind of in a rapid-fire fashion to get through as many studies as we can and kind of bring home as much information to you as possible. So this is the first study. It's a little bit of a wordy slide, so you might have to kind of read through quickly. But really, this kind of, again, hammers home the practical nature of our talk. Really kind of stuff that you're going to be seeing day in and day out in your practice. So I know you guys all have access to RNA signatures. Yeah? No? All right, so maybe not quite practical yet. This may be coming, along with Elon Musk and self-driving cars and asking Alexa what's wrong. But I did think the pictures were pretty, beautiful colors, so I wanted to throw it in there. All right, so first we're going to get started with step by step. This is, again, the eternal quest to try to figure out what to do with febrile infants. And this has been going on since I was a med student, so 30 years it's kind of evolved, looking for some practical way, some type of algorithm to try to help classify a group of infants. And these are the infants 0 to 3 months. And it's kind of changed over time in terms of the age groups, but try to figure out which group of infants, these febrile neonates without a source, which group you can classify as low risk and potentially send home without a full sepsis evaluation, antibiotics admission. So this study was done in Europe at 11 different pediatric centers. And basically what it does is it's trying to take kind of all comers, and they took infants from 0 up to 3 months, included them, and then kind of basically use this algorithm to try to classify a low-risk population. So it's prospective in nature. All these kids got a UA, they got a urine culture, they got blood, CRP, and procalcitonin. So procalcitonin has kind of become the new darling of PDM literature, and it's also made its way into the adult realm as well, but trying to look at it as a marker for serious bacterial infection. So they compared the step-by-step, which is this new approach, to Rochester, which has been around for probably 20, 30 years, and then also LabScore, which has been around for about 10 years. And LabScore also uses CRP and procalcitonin in addition to CBCs, again, to kind of use a point system to, again, try to classify this low-risk population. And what they were considering as low risk were those kids without invasive bacterial infection, and they defined that as bacteremia, meningitis. It's notable that they did not include UTI. And UTI, if you're looking at all comers in the neonatal and infant age group, is still probably the predominant bacterial infection. So again, this does not include that as what they consider invasive. And what I'll bring your attention to, so when they compare these, it was really the step-by-step that showed to be superior. Most notably, its sensitivity and its negative predictive value. So basically, all these kids come in, you start at the top. If they have an abnormal assessment triangle, so they're working hard to breathe, they have abnormal vital signs with regards to tachycardia out of proportion to their fever, they are ill appearing, it kicks them out automatically. They get put into this high-risk group. And it was interesting that about 90% of kids, 89–90% of kids were kind of culled out at that point. So if they were ill appearing, the kids that eventually went on to have one of these invasive bacterial infections, they were kind of culled out right at the beginning that they looked ill. So if they were not ill appearing, in this study, they consider over 21 days as your next cut point. So each of the different algorithms, Rochester, Boston, Philadelphia, each kind of use a different age population as a higher risk population. This one they use 21 days. We classically think of 28 days as that less than 28 days as that most vulnerable population. They go down as low as 21. So if you're over 21 days, again, you kind of flow down to the next cut point, which is white blood cells in the urine. If there were, and so therefore at risk for UTI or UTI with bacteremia, again, you get culled out. If you did not have any evidence of UTI, then again, now you go down to your procalcitonin. They use that as a cut point of 0.5. If that was less than that, you went into this looking at CRP and your ANC. And again, if you were less than those parameters, again, considered a low risk patient. And what they found is if you float this chart and you're considered low risk, the negative predictive value, and again, with febrile infants, what we're looking for is not missing any children who potentially have a serious invasive bacterial infection. The negative predictive value, so if you were flowed through all the way down, made it to the low risk category, the negative predictive value is 99%. And when compared to Rochester and step-by-step, it was shown to be superior. What is notable, so in the kids that were classified as low risk by step-by-step, there were 991 of those. There were 7 patients that ultimately were found to have invasive bacterial infection. Of those, the cautionary tale with this is that there were kids less than 30 days. So again, I kind of come back to that those kids less than 30 days are kind of like your old people with dizziness or fatigue. They are just kind of a problem waiting to happen. So I don't think there's been any criteria that have been defined that adequately can classify a child less than 28 days as low risk. And of those, 4 of those 7 patients were classified, were those kids less than 30 days. The other is that if kids present very early on in their illness, so 3 of the 7 were presented to the ER only an hour after fever began, or were found to be febrile upon arrival to the ER. So the thought being is that this fever is just not present long enough for some of these inflammatory markers to rise, and therefore they were did not adequately classify those kids. So the recommendations were if kids are presenting in that very early time period, that perhaps they're observed in the ER for an adequate time to, 1, make sure that they continue to be well appearing, and 2, just to give you time for if these inflammatory markers are going to rise, that you give them time for that to happen. Okay. I'll turn it over to Tim.
So this is literally the study we're going to talk about. It's the effect of dilute apple juice and preferred fluids versus electrolyte maintenance solution and the treatment failure among children with mild gastroenteritis. The study even makes me laugh a little bit that we're even going to talk about this, but this is going to be somewhat important. And mainly this is sort of the setup of mild gastroenteritis. The patient comes in, they're telling you the patient's not peeing very well, they had a little bit of vomiting and diarrhea. What are you supposed to give them to drink? We all know Pedialyte tastes absolutely disgusting, and from what we find that after about 6 to 12 months, kids actually start to realize that it tastes disgusting. You think to yourself, boy, you can't give them apple juice because it's just going to make the diarrhea worse, and so you keep shoving the Pedialyte at them, and the kids that are a little smart and have a little bit of a good palate won't drink it, and then you're kind of in this situation, and if you're in your small yard, your charge nurse is staring right through you, not wanting to put that IV in, not wanting to waste the time and the resources to do it, you may not even need to use it. Can we actually just give the kid what they want to drink and have success with that and turn these kids around? So that's exactly what they did. They basically just compared patients with mild gastroenteritis and gave them either apple juice or Pedialyte, and that was sort of the differentiation. And they basically just were looking at what treatment failure is and see if the two were equivalent to one another. So they defined treatment failure as hospitalization or requiring an IV start and IV hydration, whether patients had a subsequent unscheduled physician encounter, protracted symptoms like continued emesis, physician requests to change the solutions, or greater than a 3% weight loss at follow-up. And basically what they found is that the treatment failure rate for apple juice was about 16%, treatment failure rate for the electrolyte solution or forcing Pedialyte on the patients was 25%, only 2.4% of the apple juice patients versus 11% of the electrolyte solution patients required IV hydration, and they noted the benefits were most notably those patients greater than 24 months old, or those kids that would have more of what you'd call more of a selective palate. Not making this real difficult, basically give the kid what he or she really wants to drink. That's probably the most important thing. They didn't find very many effects with the osmotic load of the juice. Again, from a very practical standpoint, just give the kid what he or she wants to drink. If that's apple juice, if that's Gatorade, there's not too many side effects from it, and hopefully this can just, if anything else, just avoid 1 or 2 unnecessary IV starts for you during your shift. And just make things a little bit easier on both yourself and your staff and the kids themselves.
So when Tim told me you wanted to do this study, there was also the other one that this past year that got a ton of press was the quick-wee method. So there's an entire study about how to get infants to pee by rubbing a cotton ball in their suprapubic region. And so if we discuss that, we might as well just hang a big fuzzy bear on our stethoscopes, and we're gonna lose all credibility in this room. So I tried to pick something a little bit more, I don't know, maybe I consider it important. Maybe if I chose the quick pee method, I'd still be in academic medicine, kind of choosing that as my niche as to how to get babies to pee. But instead I chose basically the comparison of the PCARN, so the clinical prediction rules for clinically important brain injuries after bloodhead injury. So PCARN, that's a large 25 children's hospital, kind of regional children's hospital network that are working to gain large numbers, large patient populations to try to answer some of these important clinical questions that require large populations to kind of make some determination on. So the PCARN, this is a secondary analysis, so basically it was trying to come up with, again, kind of an algorithm or a set of guidelines to help decide which kids are at risk for, again, clinically important traumatic brain injury, and to try to help classify them as worrisome and do they or do they not need a head CT. So this was a secondary analysis. The original study had 43,000 patients. This study used almost 9,000 of those. What they define as clinically important would be death, intubation, neurosurgery, and in hospital admission. So again, I think this kind of falls into a little bit of the art and the science of these, what you consider clinically important. You know, what's clinically important to a parent versus us may be vastly different, but this is the definition that they used. And then basically all these kids, they polled the physician and asked them, you know, what's your suspicion that they have a clinically important injury? They kind of classified it as less than 1%. They're worried that they might have a clinically important injury, and then kind of use these cut points greater. So the algorithm here I have on the right-hand side is from the original study. So it kind of also shows you, they divided up into kids less than 2 and the kids over 2. And in this slide I included it, so it kind of tells you what the risk at each of these cut points were. But so for kids that there was a clinical suspicion for traumatic brain injury, about 94% received a head CT. But it was also interesting that the physician was polled and they felt like there was little chance, so less than 1% that this kid had a clinically important injury. Still 27% of those kids got a head CT. And then what they found was that the prediction rules were significantly more sensitive, meaning they're kind of picking up injury than the physician's clinical suspicion. So even in these kids, some of them where the clinician thought they had a little chance of having a clinically important injury, about 17 of them did, and those kids would have been identified using the PCARN rules. So this is again one of those studies that show you that if kids kind of fall into this low risk category, by PCARN you can feel relatively safe that their risk for injury is low. The specificity though was much better for clinician suspicion, meaning that if the clinician thought the kid had an injury, more than likely they probably did have an injury, a clinically significant injury. So it's kind of going back to that little voice that talks to you, you know, when you walk in the room not being dissuaded by prediction rules and algorithms, that if something is telling you something's wrong in this room, even if they fit into this, and they kind of go through it, don't have necessarily have these risk factors, go ahead and get the CT. But if you're not worried and if you think their risk is low and they meet these low risk criteria, then you can feel relatively reassured that these kids do not have an injury and you can probably avoid getting the CT. So in this case, 27% of those kids probably didn't need to have a CT, and you could have probably felt confident having met these criteria, you didn't have to get one.
So we thought with the February timing of the conference that bronchiolitis would sort of be more of an issue and be a little more apropos to the situation. Fortunately, flu kind of stole its thunder, but I think we've always sort of found in pediatrics that a lot of adult physicians will always question, what do we do with bronchiolitis? How do we handle it? It's not a whole lot new. We thought we would just bring this study up. And so this is the effect of oxygen desaturations on subsequent medical visits in infants discharged from the emergency department with bronchiolitis. Basically, the patient that's in your emergency room, if they're on continuous pulse oximetry, they may have a 2 to 3 minute desaturation in the department and then goes back up above 90%. Do you have to admit that patient? Is that patient going to have more issues long term or anything else? That's basically restating that side. So Basically what they did with these is they took patients that were deemed discharge worthy by the physician in a pediatric ER and sent them home with a home pulse oximetry monitoring system that was on the foot. And then they had the patients come back and return the monitors while they were monitored at home for about 72 hours and then reevaluated the data from there. What they found was that while at home, and again, these are patients that were sent home, they found that when reviewing the data, that 64% of these healthy infants that were found to be discharged home had at least one desaturation, and 90% of those were greater than a minute, and only 36% had no desaturations. And then the median desaturation was around three and a half minutes or so. So most of these patients that we're presuming are safe for discharge home are actually going to have some desaturations. We're just not catching them while we're in the ER necessarily. And then 24% of the desaturation group had an unplanned follow-up visit, and 26% of the non-desaturation group had an unplanned follow-up visit, or the family felt the need to return back to the ER. What's the take-home point from this study? Is that infants are going to have intermittent desaturations at home. Intermittent desaturations don't really predict bronchiolitis morbidity. And here's probably the key, is that intermittent desat does not automatically lead to an automatic admission. Which I think is probably key if you're working at a hospital that doesn't have a pediatric unit, and this is going to require sending the family an hour or two away to a pediatric facility. Just because they're having an intermittent desaturation for a couple of minutes in your department doesn't automatically mean they need to be admitted. $1 million question from our standpoint always is, what needs to be admitted? And you pretty much talk to any PEM doc and they'll tell you basically, if they're greater than 1 month old, if they're feeding well, if they're not having constant hypoxia less than 90%, and they have follow-up, and they have a family that at least looks like they can take care of them, that's probably a patient that you can safely discharge home. And I would just tell them that, what the things to look back for and to come back for.
So you probably noticed a theme here. So Tim, he's looking into the nuance. He's trying to really kind of parse the best way to treat patients. I'm all about just, I don't want to kill you. So I'm kind of going along with that theme here. So syncope, the question is, we see all these kids coming in with syncope, and which ones do you have to worry about? Which ones can you safely send home, not have to worry about cardiac disease, because that's what we're all worried about. Which kid is who's had syncope, I'm going to send out, and they're going to keel over on the basketball court because I've missed some type of cardiac lesion. And the vast majority of kids presenting with syncope are going to be neurocardiogenic, vasovagal in nature. So it is the rare circumstance. In this study, they looked over a 4-year period of kids who presented to their ER with a chief complaint of syncope. And they had over about 3,400 patients. And they literally had 3 patients that had undiagnosed cardiac lesions or cardiac dysrhythmias. So the vast majority that come in who've had a syncope episode, if it's something worrisome in nature, they're going to have some type of preceding cardiac history. So some type of congenital heart disease, a diagnosed or pre-diagnosed arrhythmia, SVT or Wilson-Parkinson-White, some type of dysrhythmia that's already been diagnosed. They've had congenital heart disease has been repaired. So that's going to be your vast majority of kids that come in who have some type of a worrisome syncope episode. But for those who don't, so those who just kind of present de novo, it really is all about history and physical exam. There is, in terms of taking kind of a shotgun approach and doing tons of studies, it really should all be guided by history and physical exam. And what this study sought was, are there specific historical features that you can kind of hang your hat on that, if present, would make it more worrisome that these kids may need further follow-up, because could they have some type of cardiac lesion? And these are the 4 things. So syncope during exertion. So again, that's not the kid who runs around and then stops and then is walking and then kind of passes out. This is the child that, while they're engaged in physical activity, they drop. 2, kind of exertion with chest pain. So we see tons of kids coming in with chest pain, most of it being reproducible. Again, the vast majority being musculoskeletal or costochondritis in nature. But this is the kid who has chest pain during exertion. Next being palpitations. So sometimes it can be difficult to kind of parse out what are palpitations, especially when you're talking with a child that's maybe a little bit younger, where they can't quite characterize what they felt, but the presence of palpitations. And then the lack of a prodrome. So to me, the prodrome, the kid feeling it coming on, feeling kind of funny, woozy, dizzy, their vision kind of tunneling in, they're feeling clammy, nauseated. So the presence of a prodrome is reassuring that it most likely represents a neurocardiogenic or vasovagal event. So the lack of a prodrome. And what they found is that if, you can see here the different proportions in terms of sensitivity and specificity for each of these features, but if they had 2 of them, then that was 100% sensitive and specific, meaning that they did not miss any of these 3 kids that ultimately had some type of cardiac lesion. So again, kind of the take-home point being is that this all depends on a really good history and physical exam.
So the next thing we're going to talk about is basically a randomized trial of dexamethasone versus prednisone for children with acute asthma exacerbations. Just as a poll, raise your hand, who uses dexamethasone for their pediatric asthma exacerbations? And then the flip side, is everybody else using prednisone? Is that kind of the... So I would say for me, I joined the group here about 18 months ago, around 2 years ago, after having worked in North Carolina before. We exclusively use prednisone. I think this is probably one of the things that I've changed the most over the last 18 months to 2 years is switching over to using dexamethasone. I feel pretty strongly about it since using it. I've had good success with it here, and really would encourage people that are using prednisone, which we'll talk about why at the end, why I just think it's such a better drug to be using and much more simpler both on the families. And basically, so the objective here was to determine whether 2 doses of Decadron, so a dose in pediatrics, of course, is mg per kg, so 0.6 mg per kg. They use a max of 12 milligrams. This is effective of 5 days of prednisone. And the dosing in this study is 1.5 mg per kg per day in improving symptoms and the quality of life. Again, here's just the intervention. The follow-up was basically phone interviews at 7 days and at 15 days. And their study measure was the PAC score. The PAC score basically looking at quality of life. Are you still having wheezing? Are you waking up at night wheezing? Are you back to school? Are you having issues with exertion while wheezing, while like physical education at school? They also looked at the admission rates as well. This was a non-inferiority study, so basically looking to make sure that the 2 drugs were essentially the same, that Decadron and prednisone functioned the same, so that you'd have no reason to say that prednisone would be better than Decadron, so that's why we're looking at these scores here. So that the PAC scores were essentially the same, 56 to 58%. Hospital admission rate, basically right around the same, very low numbers. School days missed, always important in the adolescent population, right around the same, 1.8, or right around 2. Parental satisfaction was equally the same. And then adherence to treatment, which these numbers seem crazy that in the Decadron group that 99% of the parents are reporting that they follow through using the medicines. I can't imagine that that's 100% true, but that's sort of what they're reporting in this study. There are multiple studies going all the way back, even a Cochrane database review of Decadron versus prednisone that goes back into the late 80s. There's multiple studies and also multiple dosing studies. The study that we picked to use was a newer study and also sort of mirrored our dosing regimen that we use here in Savannah. There's multiple studies, as you can read through here, that show no differences basically between the 2 groups. So our take-home point mainly is that we strongly consider giving the dexamethasone 0.6 mg per kg for 2 doses versus 5 days of prednisone. There's really no differences between the 2 medicines. What you're mainly asking the family then is you're gonna give a dose of steroids in the emergency room. You're gonna know that even if the family doesn't fill the prescription, you're gonna get 2 to 2.5 days worth of steroids within the patient. And then on top of that, you're only asking the family to have to give 1 more dose of steroids at some point within the next 24 to 36 hours. As opposed to sending this patient home expecting them to give 9 more doses of steroids. And I can't even give my dog 9 doses of steroids or 9 doses to remember to do that. Just trying to keep these patients from coming back, because I sometimes feel helpless when you send these patients home with asthma and they're 8 and they can't breathe and they can't take their own medicines, and you just know the family's not going to give them the medicine. So if nothing else, that first dose of Decadron gives them at least a fighting chance from having to come back and at least resume getting back to their normal lifestyle. One other point here is how can you give the oral Decadron if you're not familiar with it? The oral formulation of the Decadron can be very difficult to actually get from the pharmacy, just at any outpatient pharmacy, and it tastes terrible. So what we'll do here in Savannah is we will crush up the little pills, and so our nurses will crush them up, and then they'll pull it up in 3 cc's, and here it is again of apple juice, and then give it to the patient like an oral medicine if they can't take the pills. You can also just take the IV form and it's dosed the same and just pull out a small amount, or how many ever milligrams you need. And again, mix that in a syringe with some apple juice and administer that to the patient as well. But this is something we feel pretty strongly about here, and I would say this is probably, I mean, upwards of 99% of how we treat all of our asthma patients here in Savannah.
we're going to go and stop there. We included a couple extra studies just in case, so you guys can certainly look at that in the rest of the notes. But just wanted to open it up to any questions that you guys might have.
What are you doing with your pediatric sick leave that you are worried about? What's your disposition?
If those probably just if they meet those criteria and they're well appearing, I will restrict their sports participation and have them follow up with cardiology. In which case they would get an echo. They'll review a repeat EKG. Sometimes they may do a Holter monitor if it's a situation where the kids have felt palpitations and we haven't been able to identify any pre-excitation on their EKGs in the ER. They'll put them on a Holter monitor, see if they can capture any dysrhythmia. Yes?
What's your protocol for pediatric concussions in sports?
So, if you want to take that.
Our basic protocol, more than anything else, we don't have I don't know what you guys have, and I mean, who's talking next, he may have some thoughts on that too. We mainly will do would be to pull them out for about a week or so and have them follow back up with their pediatrician before returning for clearance to sports. Pretty adamant about we won't clear them, so we usually tell the family, follow up with your pediatrician, usually within about 24 hours for an initial visit, and then in about 7 days, especially during football season, for returning to sports. We're pretty thorough with that and give them a note to hold them out of football. You also have to investigate too, especially when you're getting into high school sports. A lot of the schools, at least in Savannah, have trainers and training programs. They're usually pretty good about letting the trainers follow up with them too, and then they usually will refer back. For our really sort of chronic post-concussion symptoms, we will refer them to pediatric neurology, but that would probably be in a very few instances.
Yeah, I kind of mimic that, and then I will classify them as grade 1 through 3 based on the American College of Neurology, and tell them to stay out of play, kind of in accordance with those recommendations. But every commentary that I've heard in terms of kind of the ER's role in terms of clearing these kids is that you are just looking for trouble, that we have no business clearing these kids for return to play, that this should be done by their primary physician or a neurologist if they're having more chronic symptoms. I'm sorry? We have not been. There's some literature out there looking at that. We have not. The way I kind of approach it is I use some of the literature out of Boston Children's, where they kind of did a stepwise approach in terms of kind of screening kids. First, initially with simple skull films. So if they had a very low suspicion for intracranial injury, and you had concern based more on age. So in their kind of protocols, they use kids less than 3 months. If they have anything less than a trivial injury, they would screen those kids. Then they kind of divide it 3 months to a year. If they had any hematoma formation, they would screen those kids. And then over a year, being a kind of boggy hematoma, then they would screen those kids. And then again, in their progression, they will do a skull film first. If they had fracture, they would then go on to doing a CT scan. So I've kind of followed that approach. And if I had, and you could criticize that, if you really want the information and are going to act on it, just go straight to CT. So if a child, using PCARN data, if they have some of those worrisome features in terms of risk factors in that less than 2-year age group, or if they have some of the high force mechanisms, then I would probably go straight to CT. But again, if it's kind of a low risk child that I have very low concern, we will screen with a skull film.
Anybody else?
Thank you.
Okay, thank you.